Good afternoon, doctors.
Okay.
Welcome to this webinar, Carbetocin in Action, Case Studies from Labor Room from Heathrow. Heathrow Healthcare, as doctors you know, we have 25 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in our portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We are Asia's largest manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is a 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customer across India, wide product range encompassing multiple specialties and pioneering in quality and innovation. We have distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's webinar focuses on carbetocin in action, case studies from labor. Doctors will agree with me that carbetocin, which is a drug which is used for prophylaxis of PPH, PPH we know is a potentially dangerous condition and can lead to disaster. We always hope not to see a single patient of PPH in our practice. PPH is wonderful to discuss, wonderful to present, but one should never get a PPH because of the potential danger. Although there are many papers and studies on use of carbetocin and PPH, we always would like to have our own doctor's experience of use of carbetocin in PPH. Today for that, we have got experts. Today we have got Dr. Nanditha with us. Welcome, madam. Dr.
Good
Nanditha,
afternoon.
yes, MBBS, DNB in Obstetrics and Gynecology, Fellowship in Reproductive Medicine, Diploma in National Board, Fellowship in Reproductive Medicine for a period of 1 year. Madam has been Senior Resident in the Department of Obstetrics, AIMS, Mangalagiri for a period of 2 years and 6 months. At present, working as a consultant in Sri Ram IVF Center, Vijayawada. Welcome, Dr. Nanditha, and over to the session.
Good afternoon. Good afternoon, everyone. Can you see me?
Yes, madam, we can see.
Yes. Good afternoon, everyone. Today I'm sharing my experience with the Carbetocin. The Carbetocin is a safer, smarter, and superior choice in the management of the PPH. Before that, just we'll have a brief overview of postpartum hemorrhage. What is a postpartum hemorrhage? We all know that the postpartum hemorrhage is defined on the amount of the blood loss. Blood loss of at least 500 ml following vaginal delivery and blood loss of at least 1000 ml following cesarean section. We call it as a postpartum hemorrhage. And the postpartum hemorrhage is common and can occur even in a woman who are not at risk. Uh, uh, Postpartum hemorrhage is the leading cause of the maternal mortality, and it accounts for about 35% of all the maternal deaths. Maternal mortality rate ratio in developing countries was 240 per 1 lakh live births, whereas in developed countries it is just 16. The incidence of PPH is reported as 2 to 4% of the vaginal delivery and 6% of the cesarean section. Next slide, please. Okay. Etiology of the postpartum hemorrhage. The most common causes of postpartum hemorrhage is because of an atonic PPH or like traumatic PPH, coagulation disorder, or it may be because of any retained products of the conception. In all these causes, atonic postpartum hemorrhage is the most common cause. It accounts for around 70 to 80% of the postpartum hemorrhage. Usually, what will happen is after the delivery of the baby, myometrium contracts and it constricts the blood vessel, which acts as a living ligation. If this fails to happen in case of a relaxed myometrium, then atonic PPH will occur. Next is the traumatic PPH. It accounts for 10 to 20% of the PPH. Various injuries to the birth canal, rupture, uterine inversion, and lacerations will cause traumatic PPH. And coagulation disorders are very rare, and if it occurs, it is dangerous, and it is anticipated in case of an IUD, placental abruption, and in case of a severe bleeding. Depending upon the amount of the blood loss, degree of the shock will be present. If the blood loss is 10 to 15% of the blood volume, that is 500 to 1000 ml, usually there won't be any change in the blood pressure. But there will be slight rise in the pulse rate and there will be palpitations and dizziness because of the increased pulse rate. If the blood loss is 1500 ml, that is 15 to 25% of the blood volume, then the systolic blood pressure will fall up to 80 to 100 mm of mercury, and there will be symptoms and signs like weakness, sweating, and the tachycardia. And if the blood loss is up to 25 to 35% of the blood volume, that is 2000 ml, there will be marked fall in systolic blood pressure, and one should not wait for this situation to happen. And if we keep the Foley's catheter in this condition, we hardly see the urine. There will be oliguria or anuria. And if the blood loss is 3 liters, that is 35 to 45% of the blood volume, then the systolic blood pressure will like a profound fall in systolic blood pressure, that is 50 to 70 mmHg. And the patient will, there will be anuria, air, hunger, gasping, and the patient will collapse. Next slide. So next, how to diagnose the postpartum hemorrhage? We all know the definition of the PPH, that if the amount of blood loss is more than 500 ml in vaginal delivery, and if the amount of blood loss is more than 1000 ml in cesarean section, we'll call it as an PPH. But the accurate estimation of the blood loss is very challenging. Most of the times, we will either underestimate the amount of the blood loss or we will either overestimate the amount of the blood loss. But underestimation of the blood loss is problematic because it delays the diagnosis of the postpartum hemorrhage. When we delay the diagnosis of the postpartum hemorrhage, eventually it will increase the maternal morbidity and mortality. So what we have to do is we have to keep in the mind the patient's physical status and the signs and symptoms like tachycardia and hypotension has to be taken in mind for diagnosis of the postpartum hemorrhage. What is the initial evaluation? Initial rapid assessment of the patient's status, signs and symptoms like tachycardia and hypotension has to be assessed. While after diagnosis of the postpartum hemorrhage, we have to examine the patient simultaneously in order to know the cause of the hemorrhage. In case of an atonic postpartum hemorrhage, we will see the soft, boggy, or non-contracted uterus. If we suspect any trauma, like in case of an instrumental deliveries or like prolonged labor or precipitate labor, we have to examine the genital tract rapidly and have to see for any cervical tears, vaginal lacerations or tears, hematoma, or any signs of uterine rupture is there. Have to manual examination has to be done for any retained placental tissue. And if bedside ultrasound is available, if ultrasound is available in the labor room, then bedside ultrasound has to be done to check if there are any retained placental bits are there. Laboratory assessment, if after diagnosis of the PPH, we have to send blood tests like hemoglobin, coagulation studies, hematocrit, and assessment of the fibrosis is important. Next slide, please. We all know the approach towards postpartum hemorrhage. Today, I just tell about the uterotonic agents, what all available uterotonic agents are there, and how carbetocin is superior to the oxytocin. Next slide, please. Okay. What is the rationale for the development of carbetocin in new heat-stable formulation? Actually, we all know that the postpartum hemorrhage is a disastrous condition. The active management of the third stage of the labor is important in reducing the deaths or maternal morbidity due to PPH. What are the main components in the active management of third stage of the labor is use of uterotonics for all the deliveries, vaginal delivery and the cesarean section, controlled contraction, and continuous assessment of the uterine tone during after the delivery of the baby. What are the currently available uterotonics are oxytocin, misoprostol, carbetocin, ergometrin, and the ergometrin and the carboprost. The problem with the oxytocin is it has a shorter half-life, so it has to be given in multiple doses, and it requires special storage issue system. Like it has to be stored in refrigerator at a temperature of 2 to 8 degrees. What is the problem with ergometrin is it has to be it has also to be stored in a refrigerator. It requires special storage system and it has side effects like nausea, vomiting, rise in blood pressure, all those things. What happens with the carboprost is it is associated with side effects and risk factors. It should not be given in bronchial asthma and it has side effects like loose stools, vomiting, all these things. And misoprostol is not as effective as other uterotonics, and it is also associated with side effects like rise in temperature and like shivering, all these things. All these concerns is addressed by the carbetocin. That's why, yeah, can you go to back slide? Back. Yeah. That's why carbetocin has been developed. Um, Carbetocin is stable at room temperature. It has a shelf life of 24 months at 30 degrees and 75% humidity. And it doesn't need any cold chain storage and logistics, and it is provided in bulk. Oxytocin and ergot alkaloid should be kept in refrigerator to avoid degradation. After degradation, we can't give how much effective it is, we can't give assurance. Heat stable formulation of oxytocin is currently not available. Previous formulations of carbetocin should be stored between 2 degrees and 8 degrees. Resource poor countries do not always have cold chain transport and storage capabilities. Next slide. Next, carbetocin is a synthetic long-acting analog of oxytocin. It is used for the prevention of postpartum hemorrhage due to uterine atony. One vial contains 100 microgram of carbetocin in 1 ml solution for injection. Even though it is similar to oxytocin, due to some structure is almost similar to the oxytocin, but it has some modifications which prolongs its half-life, reduces enzymatic degradation. Next slide, please. What is the clinical evidence? WHO champion trial. This is the largest trial in the prevention of the PPH. It is a double-blinded randomized trial. It compared the effectiveness and safety of heat-stable carbetocin to oxytocin in the prevention of PPH after vaginal birth. It was conducted in 10 countries, which included India, and it enrolls around 30,000 women. The primary outcomes were the proportion of the women with blood loss of at least 500 ml or the use of additional uterotonic agents, and the proportion of the women with the blood loss of at least 1000 ml. Next slide. Now, we can see that the blood loss of more than 500 ml or the use of additional uterotonics, carbetocin and oxytocin are almost similar. It is 14.5% in carbetocin group and 14.4% in oxytocin group. And for the blood loss of more than 1 liter, it is 1.51% in carbetocin and 1.45% in oxytocin group. And it is proved that carbetocin is non-inferior to the oxytocin for the prevention of the blood loss of at least 500 ml or the use of additional uterotonic agents. The Cochrane review on carbetocin for preventing postpartum hemorrhage from 11 studies involving 2635 women. It has concluded that for women who undergo a cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometry in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer adverse effects. Next slide, please. Recommendations. The WHO has included in December 2018, WHO has included the carbetocin in essential medicines, and it has we can use carbetocin for the prevention of the PPH, and it is as effective as oxytocin. And FIGO guidelines also included the carbetocin. Almost all the guidelines has included the carbetocin for the prevention of the PPH. Next slide. With carbetocin. Next.
Coming to your experience with carbetocin, madam, since how long have you been using carbetocin?
Sir, I'm using carbetocin from a period of 1 year, sir.
1 year. And in all these cases, you have used intravenous or intramuscular?
Sir, in almost all the cases, I'm using intravenously only.
You have used a bolus injections, low IV, or infusion?
Sir, single dose, I use it intravenously and slowly over 1 week.
Slowly, yeah, gradual over a period of one. So that there is no heart
Yes.
effect, there is no cardiac effect of this. Correct.
Yes.
Yes, that's what many people do. And in this 1 year that you have been using, any untoward effect you have seen of carbetocin? Any
Sir, can you repeat?
any side effects?
No, sir, I have not seen any side effects with the carbetocin, and I have seen it is when compared to oxytocin, what I have felt is the prevention of uterine tone or amount of the blood loss is very less
Less
when compared with oxytocin,
oxytocin.
and additional need of uterotonics also is less with
Much
carbetocin.
less, yes. What patient profile you can expect, where doctors can expect at PPH? Of course, you can expect PPH in any patient, that's a golden rule. But then any patient who are predisposed to PPH?
Yes, sir. Especially in case of an where we will prepare for PPH is elderly priming,
Elderly,
grand
yes,
multipara,
yes.
anemia, when infections are there, abnormal that is a
Okay,
like
okay,
abnormal attachment of placenta.
okay.
Whenever there is over distension of the uterus in case of an polyhydramnios, macrosomia, or a twin pregnancy, we will anticipate the PPH and we'll prepare to the management of PPH.
Madam, does diabetes or hypertension predispose patient to PPH?
Yes, sir. Hypertension, it is a risk factor. Diabetes, if it is well managed, diabetic diet, and the size of the baby is normal without macrosomia or polyhydramnios, so usually we won't see any PPH. Sir. Definitely, if there is macrosomia or polyhydramnios because of overdistension of the uterus, there
Course.
might be it will lead to PPH.
So, in short, anything which can dilate the uterus or anything which can blow up the uterus, or I mean, then the tone of the uterus gets reduced over a period of time, something like that.
Yes.
Anything which can reduce the tone of the uterus can make patient predisposed to
Prolonged
PPH.
labor, precipitate
Prolonged labor,
labor,
yes, yes,
uh,
yes.
all these things
Anemic patients are also, yeah, you said that anemic patients are also predisposed to PPH.
to PPH.
When would you actually prefer a carbetocin or oxytocin? Oxytocin is our textbook brand, which we have been using over years. Any specific
Yes.
cases where you would prefer, where you would suggest to use carbetocin and not wait for
So
oxytocin?
now I prefer Carbetocin over oxytocin for almost all
All
the
the patients,
cases,
yes,
sir,
yes, yes.
because oxytocin is having very short half-life.
Correct, correct.
Even the relaxation for a smaller amount of time, like a very less amount of time, will lead to the PPH.
Correct,
Whereas with
correct.
Carbetocin, after IV administration, the effect lasts for 1 hour, and for
That's enough
after
for,
IM
yes.
administration, the effect lasts for 2 hours. So I prefer Carbetocin. In high risk cases, definitely I'll prefer
Yeah, yeah.
Carbetocin.
And moreover, as you said, that storage facility is an issue in our country. The potency
Yes,
will be
yes,
reduced. Moreover, in
yes.
the periphery, all these things with power outage, I mean, you cannot expect a good storage condition. So there's a place, I suppose, where carbetocin would age over, have an age over oxytocin. Can we use any experience you have got, madam, of using carbetocin in patients with
Uh,
retained placenta?
Sir, no, sir, I have not used in case of a retained placenta. IV oxytocin I have used for a
Okay.
retained placenta, but intra-umbilical carbetocin and oxytocin both I have not used for retained placenta. Sir, whatever I have seen in in the case reports and in books only, but I don't have any
Yeah, yeah.
experience.
Personal experience. First.
Because
Can you use, what is your opinion about the use of carbetocin in RH negative mothers?
yes, sir, we can use carbetocin, and I am using carbetocin in
In
RH
RH.
negative
Yeah,
mothers
because
also.
yeah, if they get a PPH and arranging a blood, especially in the periphery, could be an issue because getting blood for RH negative, etc.,
Uh,
could be an issue. Yes.
So what happens in RH negative pregnancies? We don't know the status of blood group of the fetus and the feto-maternal blood. We don't know
Correct,
how much the
correct.
feto-mater, and we'll use standard dose only 300 micrograms. We don't know whether it is sufficient or not sufficient. As only methadone is contraindicated because feto-maternal
Yes, yes,
bleed will
yes.
be more. But I don't think so with carbetocin that amount of feto-maternal bleeding will be.
Can a doctor use carbetocin for prevention of PPH if oxytocin is used for induction?
Yes, sir. Yes,
Is
sir. We
can
are
use.
using carbetocin. Because the dose of oxytocin, what you are using for labor induction is very less, and the
Yes,
half-life of the and
yes,
duration and
yes.
effect also lasts only for few minutes. So we
The
can use it, sir.
even if the receptors are blocked, the effect will wear off, and the receptors is once again free for carbetocin to act. Correct. So we can very well use carbetocin for prevention of PPH, even if the doctor has used oxytocin for labor induction.
Like,
In which cases you would prefer IV over IM? I mean, you prefer IV is one thing, but is there any place for IM route?
yes, sir. If we need a prolonged effect, we can use IM route, but we
IM
are
route.
using the IV route
IV
only, sir,
route.
for almost for the patient. For IV route also, the effect lasts for more than 1 hour.
Correct.
So we
And PPH is a condition where you would definitely want a faster onset of action, and IV route would give you that faster onset of action, even as compared to intravascular. That's very correct. More than the duration of effect, many times the onset of effect is more important.
onset of action is like
Yes.
in case of anemia, all
Correct,
these things
correct,
we
correct.
need an immediate onset of
Absolutely,
action.
absolutely. If the patient is not responding adequately with carbetocin, what other additional uterotonics you would use?
So we can
In
use,
line of your preference, huh?
sir, methyl ergometrin,
Methyl ergometer.
carboprost,
Okay.
along with that misoprostol, or I mean methyl ergometrin and misoprostol, we can give it together.
Okay.
After 40 minutes of giving carbetocin, we can even start oxytocin.
Oxidative. Methyl ergometrin, of course, the blood pressure effect could be an issue. Blood pressure rise could be an issue.
Yes, and we have to see the profile
Yes.
of the patient, and we have to,
Yes.
it is
Yes.
contraindicated in case of an hypertension.
Hypertensive.
And carboprost, we have to contraindicate in
Asthmatics.
case of an bronchial
Asthmatics. Correct.
asthmatic
Correct.
conditions, depending.
So advantage of carbetocin or these drugs you have generally seen, but specifically over misoprostol, what are the side effects of misoprostol that you have seen? Is it as effective as oxytocin or carbetocin, misoprostol?
No, sir, misoprostol is not as effective, and
As
it has been proved in studies also. And
correct,
it is
correct.
associated with fewer side effects like rise of temperature
Yes,
and
yes, yes.
shivering, all these things. The only advantage is like when the skilled birth attendant is not there, we can tell even to the
Yes.
anyone to give misoprostol.
And
Uh,
carboprost?
with Carbetocin, the
Yeah,
concerns with
carboprost.
Carbetocin is sir, Carboprost.
Carboprost. Yeah.
Carboprost, it has side effects like bronchial spasm, loose
Yes, yes,
stools,
yes.
vomiting, all those things. It is addressed with Carbetocin, and it also requires like once in 15 minutes we have to, if there is no if the uterus has not started contracting, then once in 15 minutes we have to add the dose, next dose. But with Carbetocin, almost all concerns were
Yes,
like
yes, yes.
added, and there is no need of refrigeration.
But have you seen ADH type of side effects with oxytocin? Sodium
No, sir.
retention, water
No, sir.
retention?
No, sir. I have not seen. Yeah, as other uterotonics are there,
Yes,
like if you
yes.
need so much, then
Correct.
you should.
Should carbidopa, of course, you have answered this question. You have been using it as a
It's the
first line.
first time.
First line. How to compare adverse effect vis-a-vis oxytocin? Are there any major side effects with oxytocin other than
Sir, this water retention effect only if we like use it for a long time.
a long time?
And the direct IV bolus has to be contraindicated in case of is like in cardiovascular diseases and
Correct,
all those
correct,
things.
correct. Any change in cardiovascular parameters you have seen after use of carbetocin?
No,
Madam, your one line take message for participants on
sir.
carbetocin.
So how that's like Carbetocin is like its efficacy and toxicity is similar to that of an oxytocin, and it addresses all the concerns with the oxytocin. Like it doesn't need any special storage facilities, and it is having long life, prolonged duration of the action, easy way of administration. Only single dose is required. So I feel that Carbetocin is a very good drug, and should be used by all the gynecologists, and we have enough data also on
Correct,
Carbetocin from the
correct, correct,
WHO champion trial, that is from the Indian population only. And WHO has also like introduced Carbetocin in essential medicines. And one more thing is like no need of refrigeration, sir, mostly,
Yeah,
and
yeah, yeah.
longer duration of action.
In the periphery, that could be a major issue.
Amazing.
Thanks so much, madam. It was lovely having sharing your insights. But these insights are very important for our practicing doctors. Although there are many documents, doctors' personal first-hand use is always important. Thank you very much for sharing this.
Thank you. Thank you.
Thank you. Thank you so much. You can sign off, madam. Thank you. Wish you a very pleasant evening and happy and prosperous 2025. Thank you.
Thank you, sir. And wish you the same.
You can log off, madam. Girdhar, we can log out.
Yes.